Hi, and welcome to the MedTech Insider, where we give you an inside look to all things med device. I'll be your host today, Parker Sned, and I have an awesome guest today, Mr. Mark Farmer, our VP of Clinical Development. Mark, man, it is so good to have you on today.
Good to be on. Good to be on.
And we're here in Kansas City. You're from Lexington,
Louisville.
You live in Lexington.
Close enough.
Close, yeah.
Close enough.
So you're a Kentucky boy, but
Right.
we're having some fun here this week. You are in training with
Yep.
a huge new class. It's been fun to get to know the
I
new.
love it when the new folks come into town and they're like sponges. They're absorbing all this information and they're excited. And every class that comes in, I always think about all those patients that are out there that have never heard of our products, that are in pain, and that they're going to go out and really make a difference and go out and talk to physicians, introduce them to our products. And all those patients that have been waiting for some solution for a long time are now going to see the benefit of what we do in-house to train these folks to get out and be able to cover cases and, talk to physicians. It's cool. It's like a small child that you're releasing to the world that's going to do these remarkable things. So it's cool.
Yeah. Well, it's a full room this week, and
It's a big group.
And I know you've been doing this for a while now. We were just talking right before we started recording here, and you've been in the interventional pain space for quite some time. So give us a little bit of your background so the folks can get to know you a little better.
I started off as a therapist. I don't know if you knew that.
I remember talking about that actually. Right
I
when
started
I met
off
you.
working with kids, and I ran a group home for men with disabilities for a while, and from that I got into fundraising. My stepmom has MS. Got involved with on a nonprofit basis in fundraising, and was really good at it. And was like, hey, I'm kind of good at this sales game. And through some friends in college, and was able to start with a company called Midmark. We sold exam tables and lights and stools and sterilizers, and that's really how I got into medical sales. But it was a recruiter that called me from a small company called Advanced Bionics. They were later bought by Boston Scientific, that said, this is a role that I think you would really be good at. You talk a lot with patients. It was neuromodulation. And it was just a great fit. I got that altruistic feel good with also sales. It kind of reminded me of nonprofit. You're out doing a good deed, and you're educating people on a disease state or a foundation or a product. So it was a great fit. And I've loved interventional pain. I mean, I lucked into it just through Advanced Bionics and Boston Scientific, but it's been my home since 2007, 2008. So yeah, quite a while now.
I love that career path. And the more guests we have on this podcast and you kind of ask them, how'd you get into this? Everyone thinks there's like this linear, straight career path. Everyone has this like sort of, back and forth career path to get where they've been. And so I love that you started off in counseling and now you're on interventional pain, man. I mean, that's awesome. So
yeah.
And okay, so that led to pretty quickly though, like your expertise in the SI joint. And so let's talk about that for a minute. How did you start in that space?
From Boston Scientific, I went on to work for a company in research, Stemgenics, just stayed in that neuromod world. And there was a small company, bone allograft company, that was new to market, started there as their kind of VP of education and marketing. With a small startup company, you have multiple roles. And so in that role, I was a little bit of sales, a little bit of education, and a lot of marketing, probably in the beginning. But then it sort of went into that education more than anything, just out in the field, training new physicians, training distributors. And that was 2018, 2019. So at that time, it was kind of new to the interventional pain world. Since then, it's really taken off and I think more accepted. And there's a lot more companies out now. There's a few small companies when I first started out, but I've seen that evolve over time. I've seen from new inception to, I don't know if I want to do this, to I've been doing this for a while, and why is what you're doing better than what I've been doing in the past? I always remember back to spinal cord stim days, where I would be doing, anesthesia or paresthesia for patients. You're creating this paresthesia where you're trying to mask the pain that they have. and these patients would say, I'm hurting right here. I hurt right here. And I would try to move the paresthesia and it would get into their stomach. So we'd try to get into that. And they're like, no, right here. And they were pointing at their SI joint. But at the time I thought it was back pain. Everyone thought it was low back pain. And sometimes it was radicular, sometimes it wasn't, but I was never going to help that patient with neuromodulation. I mean, they needed some interventional, biomechanical, they needed an SI joint fusion is what they needed. And so I think back to those days all the time where there's those patients that, I don't want to say misdiagnosed, but they are going down the wrong path maybe and not seeing a solution that's out there for them.
So when did you see that mindset for the physician start to shift from like, okay, we're just managing palliative care, managing the pain to, oh, we actually might be able to give them a biomechanical solution now.
Right.
You've been in it a long time. When did that kind of shift?
It's been happening in that interventional pain space for a while, and that's why I love this space, because there's all this new technology that's constantly coming to market. You're seeing, physicians that were interventional pain physicians that were doing neuromodulation. That was probably the first step into that interventional world for them. They were doing med management, pain pumps, kind of masking that pain. Really, in the Vertiflex days, that's when you really start to see some of those pain physicians going into a more interventional space. SI joint has definitely pushed that as well. I mean, it's cool to see these physicians really latch on to an implant or a procedure and see that it works so well. Like Dr. Rasul, you had him on your last podcast, to say now I can fix these patients is that's great to be in that world. It's great to be in that world.
And so they, the physicians started to actually think about a quote unquote cure or biomechanical solution. But shortly after that, all these techniques started to evolve, right? Like there was just posterior, now there's lateral. So talk about that, and how have you seen the space evolve that way?
I mean, SI joint fusion's been around for a long time. I mean, there's documentation and research from, the early 1900s, and, it started off posterior. There was biomechanical studies and research, and it's an overlooked problem. It's an overlooked joint. I think that's why I really like it a lot too, is I don't want to say misdiagnosed, but people move to other comorbidities or morbidities before they look at SI joint. It's been typically it could be their SI joint. It doesn't show up on imaging very well. And some of the other degenerative disc disease or any of the other lumbar problems can really show up on an MRI or a CT. And SI joint is, it doesn't really highlight, medical necessity. We get imaging so that we can rule out other problems. We can rule out fracture, we can rule out tumors, but there's not a definitive diagnosis other than, physical maneuvers, SI joint injections. And I think a lot of these pain physicians were doing the SI joint injections. Patients got great relief from that. And then over time, that just didn't work as well. So when there was a solution for SI joint dysfunction that was a fix, they're like, okay, I've got these patients. We've been doing SI joint injections for a long time. I know these patients are going to do well. We've diagnosed that. But it's getting a look at SI joint dysfunction early in that treatment diagnosis is what I've seen happen the most in the last 5 years, where before it was like, well, could be their SI joint, where now it's like if someone comes in and presents with low back, let's rule out SI joint dysfunction.
The thinking of physicians have definitely evolved over the past 5 years for sure.
Big time.
When it comes to the SI joint. So, all right. So I know there's all kinds of approaches, but you are particularly passionate, I think, about the posterior approach.
I'm very,
let's talk about that.
There's a lot of passion.
Yeah.
A lot of passion.
Why do you like that approach?
I always say, and this doesn't take away from our lateral system, because I love Liberty as well. I mean, I helped launch that product, and I've anytime that I'm a part of launching a product, I always call the first 20 patients. I want to see that those patients have done well. I can't get behind something unless I can talk to the patients and see that it's helped them.
Did you do that with Liberty?
I did.
Yeah.
And those patients that did all of them did well.
Yeah.
It was great. It was great. It was, it motivates me. So, but I'm used to that posterior space, and I think it's, probably the least invasive. I want to say probably it is the most, the least invasive. It's the least amount of OR time, the least amount of blood loss, all of those things. The patients get to keep their there's no anatomical changes from the implant. It's a small implant. I like all of those things. I like the sleekness of it, and then posterior works really well. I think there's a misconception. There's been so many coding changes, and posterior works really, really well. Unfortunately, we've had some coding changes that I don't want to say forced physicians or encouraged physicians to go to a more lateral approach or a transfixing approach in the past few years. And I think now that there are implants that are out there that can come from a posterior approach and still be able to be within that 27279 code is really, really cool. We've taken, coding is no longer a barrier. These physicians can now use what's best for the patient. These physicians can now determine what works the best and what their comfortable level or their comfort level is. So I really like that a lot. I always also I want to make sure that implants pass the grandma test. Would I want my grandmother to have that procedure?
Absolutely.
And Patriot passes the grandmother test. With flying colors. Mimi could definitely get an SI.
Talk to the physician who, so they're hearing about the posterior approach from you right now. You're passionate about it.
Right.
But like traditionally in the interventional pain space, it's mostly been like an allograft product. And so now we've got Patriot, that's a titanium product.
Like we said, I started off in the allograft. And I really like allograft. And at first, when we were starting to use it, I'm like, okay, this is great because it's bone allograft. We're not leaving anything in the patient. The problem is those implants don't fuse. There's not been any long-term research to show that fusion. There's a fusion window where you're placing your DBM, but we're not getting that bridge that you have with a titanium product. That lattice work and that HA coating that we have really encourages that fusion, and we're working on studies to show that we have some really great fusion rates. And I just, for long term, I would want a product that's going to fuse and stay in place.
Yeah, and not to get too technical, but
hey, I'll nerd out.
Okay, let's nerd out. Let's do it. All right. So
if you want to.
We've talked about, so Patriot, obviously one of the differentiators is that it's cannulated.
Sure.
So when I say the word cannulated, half of the audience is probably like, what are you talking about?
Yeah.
What does that mean? What does the cannulation mean?
Yeah. That's a huge differentiator for our product and for the market. In every system that I've worked with in the past, you set up with a guide wire into the joint. That's every system. And then a tissue dilator usually follows that with a working cannula on top of that. And then in a traditional system, you would then remove everything, leaving the cannula. You remove the guide wire, and then you would lean over and get usually the drill or a decorticator or a rasp, to something so that you could decorticate that joint space. When you lean over to get that, you would either move medial or lateral, and you've completely blown your trajectory. So your working channel is in the joint, but you can move medial or lateral. And so having that guide wire stay in for the entire procedure guarantees that the drill goes into the joint, and more importantly, the implant goes into the joint exactly where you want it to be. Mm-hmm. There's no medial or lateral movement to change that trajectory. That's huge.
Yep.
That's huge.
And those small movements, right, is a big deal in the SI joint.
Oh, yeah. I mean, the joint itself is only, 2 millimeters wide. So just think about that. If you've got the cannula that's in the joint and you move just a half a millimeter, that can change the trajectory. So having that guide wire stay in place and be where it's supposed to be, and the physician knows, right, it's exactly where I want it to be.
Yeah, the technology has certainly continued to evolve with SI joint fusion. So you've been in it, like we mentioned at the beginning, you've been in this for a while. Where do you see it going from here, maybe the next 5-10 years?
Yeah, well, the coding's been challenging because it's changing. And, when people ask, like, what's the coding going to be like for 20, 27. You know, it's like the only thing that we can do is to do what we're doing at Spinal Simplicity and just do a lot of research. You know, show that this product works really well. You know, not only does it work from a biomechanical standpoint, are the patients doing well? Are we looking at our fusion rates? Are we doing well? We just need to keep our coding strong, and the only way to do that is to continue to do research. So I see the next, 4 or 5 years just being a lot more research. Adam Rogers and his team they're working on stuff right now that's pretty exciting. Can't really talk about too much of it, but we are seeing some great results, and that's going to be great when we can, release that, and I think that's going to help. That helps.
Yeah, super important to have a team like we do here. You launch a product, but you want to make sure you're evaluating it clinically, how the patient's doing for the future.
There's so many parts. That's why I love, in launching a product, because there's so many different segments to that. There's the educational, clinical, and training part of it. There's the marketing part that you guys do. All of that is so important. There's the sales part of it, that you're having to educate the sales team on how they can go out and sell the product. There's the research component to that. There's all of those entities that have to work together, to launch a product. So it's been really cool to be a part of Liberty and Patriot in launching those products to the interventional space.
That's great. Okay, let's talk about coding for a moment. Okay.
Yeah.
I mean, that's like everyone's favorite topic, right?
Sure.
Coding and reimbursement.
The clicks.
Yeah. Everyone tuned out. They're done.
Yeah.
It is relevant. I think it is relevant to this topic, though, because it has evolved so much in the last 5 years. And like you just mentioned, it's probably going to continue to evolve a little bit.
Right.
But let's get maybe specific a little bit on really 27278 and 27279.
Yeah.
Like, what has been going on with that? Where are we at today? How do our products fit into that? So as best you can there.
Yeah, it's been tough. I've been in this long enough to where I saw a pretty straightforward 27278 and 27279 and a 27280 coding, and it was either a minimally invasive or an open procedure. It was pretty straightforward, pretty cut and dry. Then with the introduction of allograft, and as that continued, there was a T code separate, a category 3 code that was separate for allograft bone. So that was tough. We had to wait that out. It was not as an easy pathway for patients, especially with some providers, for some insurance carriers. It was pretty tough. But in the recent years, and especially in 2026, we've seen that coding be a little bit more defined. Really, it used to be transfixing. That was, you had all these products that came out. The transfixer. You had a lot of products that lean more toward that transfixing code. Now it's piercing the cortical walls of the ilium and sacrum, and
so is the piercer coming out?
The piercer, the Patriot piercer. Yeah. So, with our FDA approval, it states in that FDA approval that we pierce the cortical walls of the ilium and sacrum. So I feel pretty confident that our product lies in that 27279 product code. And that's a great space to be in. There's a lot of other posterior products that are in that space. And again, I think that posterior implant is not only great for the patients, but that's the trajectory that a lot of pain physicians are used to. They're used to the imaging. I know that when we go out and we educate new physicians, especially in that spine market, they're not used to seeing that the river view, or they're not used to seeing that posterior aspect of the joint. And so for pain physicians, it's a pretty easy education, because that's an image that they recognize and they see all the time, with doing SI joint injections.
For a patient to get access to a technology like this, like, we have to talk about that kind of stuff, because it's on the policy and then the contract with the physician. Like, if you don't have that, the patient can't get it.
Right.
And so
exactly.
it's important to talk about.
Yeah.
So that was really clear, and it's evolved over
I don't even know
years.
if that's clear. I mean, it's always very, they use vague terminology sometimes, and that's difficult. And it's not, I want to use this code for better reimbursement, or, what you want to use is a code that's acceptable to insurance providers and Medicare. You want to use a code that's not scrutinized. You want to use a clear, fast, easy path to a patient getting the therapy and treatment that they need, and sometimes that unfortunately is not an easy path. Yeah.
Okay. So for the sales rep on our team specifically,
All right,
they're listening to this.
Sure.
You're coming back to Spinal Simplicity. Like
Right.
you were here, now you're back, and now you're really focusing
Right.
on Patriot specifically.
Sure.
What can you do to help them right now?
I think when we came out with, when we entered into that SI market, Liberty was our first product to get FDA approval. And we were really focused on Liberty. And we have a lot of physicians out there that have really fallen in love with it. They see that lateral approach is very simple. They see their patients doing really well, and they like that approach. We sort of slided our Patriot product a little bit. When it was FDA approved a year and a half ago as a standalone, I think we had already trained all of our reps really, really well on Liberty. We introduced it to our physician market. And I don't want to say Patriot was an afterthought, but I think that we did such a great job of getting physicians to look at a lateral view or a lateral trajectory over a posterior trajectory that we almost sold ourselves away from a posterior. And what I would say to them is go look at the research not only that's out there, but the research that we've done internally. Posterior implants work really, really well.
Yeah.
They reduce that movement within the joint sufficiently. So sufficiently that we've compared it to 2 lateral screws, just bone screws, and we had better or less range of motion than 2 lateral screws. That's a huge, huge indication that it works and it does what it's supposed to do. I would tell that rep, Patriot is not something that's a Liberty Light. Patriot is in a force of its own. And there are a lot of physicians that feel more comfortable with that posterior approach and are passionate about it like I am, and it passes their grandma test. And they see that their patients did really, really well with bone allograft, but maybe that's not a clear reimbursement path for them, and they're looking for a posterior approach that is simple, that's safe, that's effective, that works really well. I would introduce it to any physician that I talk to.
Yeah. No, I love that. And I think I would just encourage our listeners and the reps and our physicians that are hearing this today, like take advantage of Mark and his expertise and take another look at Patriot. I mean, we've had it for a year and a half, but it's time to take another look at it. And it's such a cool system.
Well, and I think with that clear coding path, that helps. We're going to get more eyeballs.
Yeah.
We're definitely going to get more eyeballs.
Yeah, absolutely.
Yep.
Mark, this has been fun, man. Appreciate the time. Yeah, it's always good to see you.
You guys are going to invite me back again down
Probably
the road,
not after this. This was wild. No. We're going to get you out of Kentucky, man. Come back to Kansas a couple times a month. You are here a lot. Is this your office over here? I mean, you might as well get one. So.
Right.
Yeah, thanks, Mark. Good to see you, man.
Thank you.
Appreciate it.
Right.
Yeah.
See ya.
This podcast has been financially supported by Spinal Simplicity. The content is for informational purposes only and should not be relied upon as medical advice. The views, opinions, and information provided by participants are their own and may not reflect those of Spinal Simplicity. Healthcare professionals must exercise independent medical judgment, and patients should always consult with a qualified healthcare professional regarding medical decisions. Finally, the healthcare industry is constantly changing, and neither Spinal Simplicity nor the participants can guarantee the accuracy, completeness, or timeliness of the information provided in this podcast.